Welcome everybody to the COVID-19 virus and vaccine Q&A tonight. We want to thank you for joining us. I'm Hamlet County Mayor Bill Britton, and tonight, there's been lots of information out there about COVID and the vaccines and what's true and not true, and a lot of confusion. So what are we supposed to believe? Well, tonight we have some trusted local healthcare providers that we're going to ask those questions to, and that you're going to have the opportunity to ask the questions to, and hopefully at the end of this hour you'll have a clearer picture of what is COVID, what's its impact, and what are the vaccines all about. We'll only be discussing the virus and the vaccines tonight. Any questions related to the school system and outside and its operations and how it's handling COVID and outside the scope of our discussion and should be directed to the appropriate entity within the Board of Education. Joining me tonight are local physicians and healthcare workers who have been and still are working on the front lines of the pandemic. I want to thank them for what you're doing for Hamlet County and our citizens. You guys are true heroes for our folks. To my far right is EMS Director Danny Housewright. To my direct right here is Dr. Jackie Livesey, the emergency room physician at Morriston Hamlet Hospital. To my left is Dr. Tom Thompson. He's a local surgeon and also the county's medical examiner. And then to my far left is Sherry Montgomery. She's the director of the Hamlet County Health Department. You'll also be hearing from Dr. Eric DeLay, who is a pediatrician with HealthStar Physicians. Now, I'd like to turn it over to Dr. Livesey and Dr. Thompson and let them briefly describe the current state of healthcare and emergency services in the county.
So I will tell you that at Morriston Hamlet, we are in the same boat as everyone else seems to be in the country at this point in time. We're very stressed. We're stressed in terms of the available space. We're also stressed in terms of the available staff that's available to take care of patients that are ill. To put that in perspective and give you some idea, we have 23 beds in our ER, and prior to the pandemic, we were seeing 42,500 patients per year. Those 23 beds now are mostly filled with patients awaiting beds on the floor at the hospital. And that's simply because the floors are stressed. They have patients that are very ill, that are staying in the hospital for prolonged periods of time. As a result, it causes a backlog into our ER to the extent where we're having an additional 13 hallway stretchers where we're seeing additional patients as best we can. To give you some idea of how difficult that can be at times, Danny or other ambulance services in the area may bring us patients. When those patients come in and we think that they're actively infected, we have to scramble to find a room in which to place these patients because we're concerned that if we leave them in a hallway, we may infect other people inadvertently. So to give you some idea of how we're trying to cope with those issues, we've been trying to think outside the box. I've even had providers going out to the ambulance to see patients in order to start that care a little bit more readily, but nonetheless, it has put a tremendous strain on the hospital and the emergency department.
Dr. Thompson?
I think one thing that oftentimes when we're focused on the COVID-19 patients and our legitimate concerns there, we forget that when the hospital system, when the healthcare system, when EMS is strained like this, it affects all care. Elective cases can be suspended because you don't have adequate staff. Cases that require admission to the hospital, there's not a hospital room for the patient to go in to recover from their surgery, so their surgery is delayed. When the emergency room facilities are full of infected patients, then that's less room for someone who's having an acute heart attack or who has a broken bone or the myriad of reasons why people would use emergency or surgical services. So those become strained. The hospital has had to shift resources in order to care for all these patients by shifting folks who are normally used to taking care of day surgery patients or recovery room patients to moving them to the floor or the unit to take care of pneumonia patients so that we have adequate staff. So the stress trickles down to all aspects of healthcare. in terms of travel, this has affected me personally. That's my primary concern. I'm more concerned about if there's an accident or if I have just a routine illness, that there's no place for me to go because I know that those ERs are full. So that makes me less likely to travel outside of kind of my safe area. From a medical examiner standpoint, we have been busier because of COVID-19. I can say since the onset of this latest Delta variant, we've had numerous more COVID-19 deaths in the community outside of the hospital, deaths at home, than we did even in the winter. We have had several circumstances where an entire household would be actively infected with COVID-19 and an older member of the household unfortunately died at home. While our resources from a medical examiner standpoint have been strained and our deputy coroners have been busy, our resources have been adequate to take care of the situation between our funeral homes and crematories and our ability to adequately care for families who have lost a loved one. But those resources have been strained.
Danny, what about EMS?
Well, I can definitely speak on the EMS topic. EMS has been extremely busy, and it's only getting busier. We've seen a 12.5% increase in volume over this past year. We've also, in that same time frame, seen a 47% increase in patient transfer or offload times at the hospital due to overcrowding, as Dr. Livesey spoke about. And I just run some numbers today, just before I left here, that 1,500 hours today, Region 2's facility status dashboard shows University of Tennessee, North Knox Med Center, Newport, Morristown Hamlin, Jefferson Memorial, all on critical advisory. Well, critical advisory means that there's a possibility, don't necessarily mean there is, but a possibility of a greater than 120-minute offload time. You can take the increased volume and the longer offload times, that creates a real possibility of no ambulances being available. But just remember, all the healthcare workers are all working hard every day. We could use your support, your thoughts, and your prayers. You can help us by utilizing 911 for true emergencies. As Dr. Thompson mentioned earlier, heart attacks still happen, car wrecks still happen, strokes still happen, and we don't need to be tying up the ER for unnecessary visits. Don't forget to use your family physician and freestanding clinics as an alternative source. By no means am I not telling you not to call 911 if you're having a true emergency. You should. But you got to do your part, and that means practice your social distancing, use proper hygiene, avoid large crowds, and for God's sakes, please consider the vaccine.
Dr. Livesey, let me follow up your all's comments. Just what about the National Guard resources at the hospital? How has that helped?
I will tell you that having those extra hands have been incredibly invaluable. My nursing staff in particular has been incredibly stressed. So they've been able to take some of the tasks away. Now, I haven't got to see them on the floor, but in the ER, they've been able to supplement the care that the nurses have provided, and it has acted as a great de-stressor for my nursing staff. So they have been invaluable, and I would be remiss if I did not thank them for their efforts.
Okay. We want to thank everybody who had a hand in getting the National Guard to respond and come. And we'll also be taking questions from you, the viewers, and we've had several that have been submitted before tonight, and so we will entertain those first. But if you want to comment or submit a question, feel free to do so and put it in the comment section there on your page. We'll begin or continue with Dr. Eric DeLay. He answered some questions pertaining to children. He's on videotape.
The first question I'd like to answer tonight is, why is the vaccine only down to ages 12 to 17? When a company applies for emergency release of the vaccine, they have to show research that it's safe down at those ages. Right now, that's what they've been able to do down to age 12. Both Pfizer and Moderna are currently in research trials to show that it's safe down to ages 6 months. The current timeline looks like that probably in November or December of this year, we should be able to do the vaccine for kids age 6 to 11. probably in the early part of the winter of 2022, say January and February, it should be released down to kids 6 months and higher. The second question I'd like to answer is, why is the Delta variant affecting kids more than the original variant? What they have seen is it's really not affecting kids any more than the original variant. The type of illnesses and the types of symptoms we're seeing was seen with the original variant last winter. What we are seeing is it's much more contagious. So you're having more kids getting sick. Remember, where the original variant would affect maybe 2 people from 1 person who was sick, this new variant, if you're sick, you can pass it on to maybe 4 to 8 people. So we're just seeing more volume, more kids being sick. If our children contract the virus, what are some things that we can do to help them? We need to keep them isolated. We need to make sure that we're using Tylenol to keep their fevers down. We need to make sure that we are keeping them hydrated. A lot of the treatments for adults, like antibiotics and steroids, are reserved more when kids have more respiratory symptoms. For kids aged 12 to 17 who have other health problems, like sickle cell disease or asthma or chronic immune problems, or kids that are on the larger size of BMIs, they actually qualify for the monoclonal antibody infusion. This is the infusion that you may have heard about with adults that basically infuse antibodies to neutralize the virus. There are several places in East Tennessee where you can get that done, and I encourage you to contact your pediatrician or your primary care provider if your child meets those qualifications. The only other thing I'm going to add about treatment is please, oh please, do not give your children ivermectin. Ivermectin is the new thing that we're seeing on social media and on the internet that unfortunately in many states, people are going to their local co-ops and farm stores and buying. That is a large dose that can make adults and even children very sick with nausea, vomiting, and diarrhea. The CDC and the FDA and the major medical associations do not recommend ivermectin for treatment either of adult COVID or children COVID. So please don't do that.
We want to thank Dr. DeLay for taking the time to record responses to those very important questions. Now, don't forget that you can ask questions or comment in the comment section. So if you have a question for a particular panelist, please address the question to his or her attention. Okay, first question that was submitted earlier, this is for Dr. Livesey. Dr. Livesey, if the monoclonal infusion is actually helping prevent COVID symptoms from progressing, why are people still dying from COVID, and why not just give this infusion to everyone who tests positive for COVID?
So that's actually a very good question. So if I could, and I'll apologize ahead of time, this answer is very prolonged, but I think there deserves some explanation as far as what those monoclonal antibodies are. When a person becomes infected, your body actually produces antibodies normally as a means to help protect yourself against an infection. So what monoclonal antibodies are something that are produced in a lab, and it's meant to identify these pathogens. In this particular case, it's the virus, so that your own immune system has the capability of then responding to that virus. Now, I will tell you that they are helpful. If you read, it will tell you that people that have very early symptoms, actually, it can prevent progression of that illness in 70% of people. That's very impressive. 70%, first of all, is not 100%. And I will tell you that while they're useful and while we're administering them ourselves these days, that still the best answer, the first best answer is still the vaccine. And let me explain to you why, the difference. When I give someone an mRNA vaccine, so I'm going to use Pfizer, I'm going to use Moderna as an example. Essentially what I'm doing, when a person inside a person's body, every one of us have DNA. That DNA is used as sort of a recipe book to allow us to make certain proteins that we can have certain functions in our body. For example, insulin. Every one of us make insulin to prevent ourselves from being diabetic. So it uses RNA. It takes from the DNA, it transcribes that to RNA, and that RNA is then taken downstream, and that's where it makes insulin. In this particular case, instead of going to make insulin, we're actually administering the RNA. It's something that we make in a laboratory that gives the instruction set to my cells to, instead of making insulin, I'm making the parts of that outside surface of the virus itself. So when I manufacture those spike proteins, they call them, what I'm doing is I'm introducing it to my body so that my body can see that that's a foreign invader, so that you can form your own antibodies, so that you can protect yourself. Now, why is that important? What's the difference between that versus taking these monoclonal antibodies? The difference is this. Those monoclonal antibodies only last a certain period of time. After 3 to 4 weeks, they're gone. You're no better off 6 weeks from now than you were when you received them the first time, which means that you're still at risk of getting infected once again. Whereas if I had the vaccine, I still carry that high percentage of likelihood that I won't get sick, that I won't spread it to others, and that I won't either end up hospitalized or even dying. That's why the vaccine is still a better choice. Just because a person gets vaccinated, they're still eligible to even receive those monoclonal antibodies as well. We actually did that with one of our own ER doctors here recently. He was vaccinated, he got sick, and we were able to administer those antibodies, and he did incredibly well. So yes, they're helpful. They're not the entire answer. I would add one other caveat, because I want people to understand this. When we use those monoclonal antibodies, they have to be used early on. This is not something that's intended for everyone. To give you an example, somebody may have an aunt, let's say, that's on a ventilator at the hospital and say, well, why can't we use those in this particular case? There's a reason for that. Do you imagine having, let's say, an infestation of mice in your home? It's much easier to take care of those mice if there are 1 or 2 of them. If your house is overrun with mice, it's going to be very hard to get rid of those. In this particular instance, COVID-19 is a little different than most illnesses. People think, okay, how do I know if I'm going to get sick? I should be better in just a few days. The thing with COVID is, while the vast majority of people do get better within about 10 days, about 6 to 7% of people get seriously ill. And predicting who those people are is very difficult. So that they get sick, not on day 5 or 6, they get sick on day 11, 12, 13, 14. That's when they tend to develop this pneumonia that we see. That's when they end up requiring oxygen. And when you see those people that require the oxygen with this pneumonia, please understand that that pneumonia is not necessarily from the virus. It's your own immune system trying to respond to take care of that virus. So it's your own immune system that's ramped up. The thought is if I give those monoclonal antibodies to those people who already have an immune system that's on overdrive, that I can make that potentially even worse. That's why it's not for everyone.
Is a follow-up on that. Does the virus impact people differently?
That's very true.
And based on what? On their health conditions, or what is it based on?
Generally, yes. And it's really hard to predict. We've had, you may have heard that there's a condition in kids, it's called MISC. It's a multi-system inflammatory syndrome in children. We've had cases of that. Now, how do you predict that this otherwise healthy child would have that? I don't know the answer. Sometimes it is unpredictable. However, there are certain things that make you more prone. Having a history of cancer, any type of immunosuppression. So, for example, if I have someone with HIV, they're going to be much more prone to getting worse than, let's say, your average Joe.
Okay, thank you. Okay, Dr. Thompson, are the deaths in our county classified as COVID-19 deaths? Are they truly from the virus?
Yes. In short, yes. By way of explanation, as the county medical examiner, my responsibility is determination of cause and manner of death for those that die in Hamlin County. Now, many of those death certificates are signed by hospitalists, by ER physicians, by primary care physicians that have cared for that patient for years. When it comes to the deaths from COVID-19, our office has been notified about every single one. We have reviewed them and assisted in the determination of cause of death. And quite frankly, it has not been difficult to distinguish those who have truly died from COVID-19 as opposed to someone who had perhaps a cardiac event and just so happened to be infected with COVID-19. We have had those occasions. Our threshold has been if this patient had not been infected with COVID-19, would they still be alive? And so I feel confident in the deaths in Hamlin County that the statistics at the Tennessee Department of Health exhibit that those have been properly determined. And there have been cases where folks have been infected with COVID, but their cause of death was determined to be something else. What there hasn't been is this push or pressure on physicians in our community or pressure on me to classify non-COVID deaths as COVID. I've read that there's perhaps some financial incentive, and I can't answer for the rest of the country, but in Hamlin County, we've not seen that kind of incentivization or pressure for us to classify something as a COVID death when it is not.
What about the vaccine? Have there been any deaths from people receiving the vaccine?
Well, in Hamlin County, absolutely not. We have not had anyone suffer anything near that type of complication from the vaccine. But truth be known, from the standpoint of the CDC and study statistics on vaccination in the United States, there's not been a death directly attributed to these mRNA vaccines in the entire United States.
Sherry, where is Hamlin County? Where are we as far as vaccination rate?
As of today, approximately or a little over 38% of our county's population has received partial vaccination or one vaccination. Approximately 32.5% of our county's population would be considered fully vaccinated, that being they've had both of their doses of either Moderna or Pfizer vaccine or the one dose of the J&J vaccine.
Now, we're part of the East Tennessee region as far as health departments go,
Yes.
correct? So how do we rank as far as the fully vaccinated or the vaccinated population compared to other?
Well, we're not the lowest, but we're certainly not the highest either. I think the highest county in our region, Loudoun County, is around 50%. Union County, I believe, is the lowest, around 20, as I recall, around 27%. However, to be honest with you, most of the counties surrounding us, Hawkins, Greene, Cock, tend to be in the higher 30s. So we want to be more aggressive in Hamlin County. We need to protect our county. We all have stressed already in what we've said, the importance of the vaccine and that it's the best tool that we have. And since this surge began, you take May to June statewide statistics, approximately 90% of the COVID cases in that period of time, statewide, May to June, 90% of the COVID cases unvaccinated. Approximately 88% of those hospitalized during that time period due to COVID, unvaccinated. 94% of the deaths in that time period, May to June, unvaccinated. So it's really hard to argue with those statistics. And I think you all would probably, Dr. Thompson especially, bear out that applies locally in a similar way here.
It most certainly does. In my career, it's the most astounding example that I've seen. It's not the kind of example you want to see, but the difference or the effectiveness of the vaccine with regard to what we see in the hospital. And it's progressive. From just an illness standpoint, you've got a fairly high percentage that are unvaccinated. Then you look at the hospitalization, then the percentage goes up. Then you look in the ICU, it goes up higher. Then you look at ventilators, it goes up higher. Now we're getting up into the upper 95 to 97% range. And then when we get to death, in Hamlin County, it's virtually all of our deaths in the last 6-8 weeks attributable to COVID are unvaccinated. It's not that it's a higher percentage. It's all of them, and that's tragic. But the reverse is it shows it's just regardless of the statistics, regardless of what you may read out there, it's plain for all of us to see the difference in the two populations. The folks that we see as the medical examiner, the folks that we see in the ER, the folks that we see in your ambulance, they're unvaccinated.
Any follow-up, any comments on what Dr. Thompson had to say?
I would,
Dr. Livesey?
I would tell you that I agree 100%. When I see patients, I will routinely ask them, "Are you vaccinated?" And it's not because I'm trying to make a point. I'm trying to find out if there are barriers that occur. And to this point in time, and I will tell you, I was in the room with the very first patient that was diagnosed with COVID last year. I was in that room talking to her about intubation. So I've seen a lot of them. And over that period of time, I will tell you that it's just so frustrating to see people suffer so much. And this causes not only suffering for the patients, but their families as well, when we have something that's very effective to prevent them from being in the hospital in the first place. The closest I've come to having anyone who was truly vaccinated, I had one person that was a week out from their very first vaccine. That was the only case that I have personally seen where someone had attempted to get the vaccine and ended up needing hospitalization. Everyone else was unvaccinated.
Okay, next question's for you, Dr. Livesey. A viewer is concerned about her cardiac risk factors and is concerned about myocarditis. Is the vaccine safe for people with heart conditions?
Okay, so let me address that if I can. So first of all, let's talk for a minute. What is myocarditis? Myocarditis is an inflammation of the muscle of the heart itself. So it is something that we sometimes see as a risk involving the vaccines. Now, more commonly, that occurs with the mRNA vaccines, the Moderna and the Pfizer vaccine. There's rare cases where it was also associated with J&J as well. Only about 6% of cases that you've seen it with J&J. Now, myocarditis can cause chest pain, shortness of breath, fatigue, weakness, etc. The good news is, and as Dr. Thompson alluded to before, in this country there has been 0 deaths related to the mRNA vaccines. 0. So what does that mean? I can tell you that the vast majority of those people recover with only supportive care, just in a matter of 1 to 2 weeks. That's it. Now, how frequent does this happen? On average, you're talking at somewhere between 1.8 to 2 cases per 100,000 vaccinated. So again, it's incredibly rare. And one other statistic I will throw out there, because I love numbers, that I will tell you that depending on who you read, you're somewhere between 4 to 12 times more likely to develop myocarditis from the infection than you are from the vaccination.
All right, Dr. Thompson, here's a question. Explain mRNA versus a traditional vaccine and the difference between Pfizer, Moderna, and J&J.
Well, Dr. Livesey touched on this earlier, but let's talk about traditional vaccines. Vaccines came about, for example, during smallpox, which was a scourge in the late 18th and the early 19th century. They figured out that if they could expose patients to cowpox, or in some cases give them a lower level of exposure to smallpox, that then they became immune, just like someone who had smallpox. Progressing from there, we learned how to give people non-infectious levels of virus, or maybe a level of virus that did not cause severe illness but did create a reaction in their immune system Then we learned to injure those viruses, if you will, so that the virus was then no longer able to cause illness, but it still created an immune response. Some call that an attenuated virus. The flu vaccine, for example. The scientists work every year to figure out and try to predict what strain of flu is going to be predominant, and then to create attenuated virus that we get for our flu vaccine. But you are actually getting virus. For a pneumococcal vaccine, you're actually getting samples of organisms that cause pneumococcal pneumonia. The difference here is we're kind of expanding the term vaccine in that we're not giving the organisms anymore. This is actually more of a biologic or immune mediator. Vaccine's a good term in that you get a shot and it gives you an immunity to an illness, but it's not a vaccine in the sense of the word that we're accustomed to. In this particular case, they have figured out how to use the mRNA that inside of our cell is translated into a spike protein that is normally displayed by the virus. Now that mRNA, if just injected into our system, would be destroyed like that. But there's a technology where they use tiny little nanoparticles of lipid or fat or an oil droplet, and they actually house the mRNA in the oil droplet. When you get the infection, that oil droplet will merge with a cell and spill its contents into the cell where it's protected, and then the cell translates that mRNA in the normal mechanism just like it does our own mRNA. Only this mRNA produces that protein, which the cell then displays, which then creates a myriad of different technical immune responses by immune cells that are called T cells or B cells, different white blood cells that create antibodies and an immune reaction. There's actually memory cells that take over that remember that reaction and can come back to it later. But that's the basic difference between an mRNA vaccine and our traditional vaccine. Now, the J&J is a little different in that it uses a virus that typically causes the common cold. And that virus has been inactivated, and they use that as a vector to carry DNA from the SARS-CoV virus into the body so that that DNA can then be translated into the spike protein and so forth and so on and create that immune response.
So the efficacy rate of each one.
Now, I wrote some of these down because the numbers are, in general, with regard to prior to this Delta variant surge that we have now, the main phase 3 trials for these vaccines that have been in use. And understand that we're nearing 1 billion doses worldwide of these vaccines. That is a large sample size, Hundreds of millions of these vaccine doses. In terms of preventing infection, prior to the Delta variant, the Pfizer effective, and these are multiple studies with a number of subjects, and we've kind of combined that to come up with a general figure. Those figures are important not just from the standpoint of infection and preventing that, but serious illness or hospitalization. We'll just stick to this current situation because the effectiveness in preventing infection of this Delta variant is slightly less, but it's still highly effective. With Pfizer, severe infection, it's 90% effective. With Moderna, basically 90%. And with the single J&J shot, that's about 80%. In terms of hospitalization, Pfizer current data says about 95% effective at preventing hospitalization. Moderna the same, J&J the same. So in other words, the vaccine is about 95% effective in preventing someone who's been vaccinated from becoming ill enough to require hospitalization.
Go ahead.
And that's where the effectiveness really is it preventing a vaccine is not like an anti-aircraft weapon that sits on your head and shoots virus out of the air. The vaccine does not prevent you from getting the virus. The virus still comes in. The vaccine just gives you weapons to fight that infection off. So you may not get ill at all, or you may have a mild illness, or you may have a flu-like illness that knocks you out of work for a while. But 95% effective in keeping you from going to the hospital and ending up on a ventilator and oxygen.
So if I could, I just want to expand on one thing that you said, just because I think it's important that people don't always necessarily understand, and that is that a very substantial number of people never get sick at all, that they're carriers and they don't realize they're carriers. They're not intending to get others sick, but that number is as high as 40%. So 40% of people may be walking around and infecting others, and they have no intention of doing so. They feel fine. But that's where a vaccine comes in handy. If we could vaccinate enough people, you may end this altogether. Viruses cannot grow on their own. They require a host. They require a body in which to grow. So the virus goes away if there's no place for it to grow.
All right, Danny, this question's from you or for you. Are the unvaccinated COVID-19 patients making up most of the transports to the ER?
Well, we don't really track vaccinated or unvaccinated COVID-19 responses. We only track COVID-like signs and symptoms that we actually take to the hospital. And we've seen an increase in COVID-like symptoms, especially last month. Was you able to pull that data? Don't think so. Well, I'll just tell you out. The data beginning January 2020 through July 2021, we averaged 37 COVID-like symptom transports a month, with some months higher and some lower, with December 2020 being the highest, where we transported 99 patients in one single month with COVID-like symptoms. That was until last month. August, we transported 110 patients with COVID-like signs and symptoms, and 7 of them we had to run in emergency traffic to the hospital because they were that severe. The hospital, but to answer your question, the hospital keeps up with the vaccination status, and their data reflects the majority are unvaccinated, so it only makes sense the majority that we transport are unvaccinated, but I can't really answer that question with 100% reliability other than the fact that the majority of the ones we admitted are unvaccinated.
You know, we've had conversations with all of us, I'm sure, with folks who are not vaccinated and question the value or the whether it would lead to other issues. Let's go with you, Dr. Livesey. What do you say to women that are expressing concerns about that it would impact their fertility?
So I will tell you that to this point, there's no evidence that it affects fertility in either males or females. As a matter of fact, getting vaccinated during pregnancy is also considered safe. Now, I'll add a caveat to that in a moment. I would also suggest if there are women that are considering becoming pregnant or currently pregnant that are interested, there is actually a program that is set up through the CDC. It's called the V-Safe program. V as in victory, safe. And what they've found is that they've enrolled over 150,000 women that they're tracking. This is completely voluntary. They can stop at any time. What they do is they track their progress through pregnancy to see if they find any untoward effects. So 150,000 is a fairly substantial number that they're following through pregnancy. And to this point in time, they found no evidence that this impacts fertility at all. The caveat I mentioned, just one thing, just to mention briefly, is that when it comes to vaccinations, J&J is probably not the first choice in pregnant women. We use the term hypercoagulable sometimes, and what that means is people are more prone to clots and clotting disorders. Pregnancy is one of those things that makes you more prone to clots. So unfortunately, we talked about myocarditis being maybe a rare side effect that occurs when we use the Pfizer and Moderna vaccines. With J&J, there are very rare instances of people having blood clots. And because of that, they have some limitations on when that vaccine, the J&J vaccine, is used. So they have specific concerns about using those in women less than age 50, and pregnancy would certainly fall into that category.
All right. The next question is for Sherry and Dr. Thompson. If a person has had COVID, When can they receive the vaccine?
They can receive the vaccine when they're out of their isolation period, which generally is 10 days, but they also need to be asymptomatic, have no symptoms, and be fever-free for at least 24 hours. And when I say no symptoms, if the sense of taste and smell has not returned, that's acceptable, but there needs to be a noticeable improvement in symptoms and
So
definitely be
So
fever-free.
someone needs to be recovered from the fatigue symptom? Or is
Not
that-
necessarily,
Okay.
no. The primary thing is to see a noticeable improvement in the symptoms and be fever-free without medication for at least 24 hours.
Anything to add to that, Doctor?
If someone has received the monoclonal antibody infusion that Dr. Livesey spoke to, then they're not eligible to then receive the vaccine for 90 days
Okay,
after they've received that infusion.
okay.
So if I could, I'm just going to
Go
expand
right
on
ahead.
that just very briefly, because we'll often hear the question, what about people that have had COVID before? Do they benefit from getting that vaccination on top of that? I saw a number, it was probably about 4 weeks ago, that suggested that you were 2.8 times less likely to contract COVID once again if you get vaccinated. So again, it gives you that added protection. So even if you've had the infection before, you still have additional benefit from being vaccinated.
Okay. Sherry, question. Let's see, this is a question that has come in tonight. Let's see. All right, I'll open this up. If the vaccine produces an autoimmune response, is it safe for people with multiple autoimmune diseases? Does it cause inflammation?
So if I could, I will just simply say this. These vaccines cause an inflammatory response just in the same way that if you get a flu vaccination, that you develop fever, chills. That's not the flu that you're contracting. That is your immune system causing an inflammatory response. So the answer to that is yes, but it's very limited. Generally, those symptoms last a day to 2 days, and then it disappears. So there should not be an issue for someone with autoimmune diseases to receive the vaccination. If you have a history of severe allergy, there's a difference, and you have to be a little bit more cautious. But strictly autoimmune diseases, no, that should not be an issue. Not that I'm aware of.
Okay, this question's for you, Sherry. What is the current recommended quarantine guidelines for infected?
For a COVID case or being
yeah.
infected, a positive case, it is 10 days is the isolation period. But there again, a person after the 10 days, if they still are experiencing symptoms, not seeing improvement and maintaining the fever, then it may be longer. And we have seen that frequently with people. But it's a minimum of 10 days.
What about those who've been exposed?
For those who are exposed, if it is truly a close contact, which would be closer than 6 feet for more than 15 minutes. So if someone is truly a close contact and they have not been vaccinated, then generally the minimal time is approximately 14 days. If they're a household contact and are unvaccinated and not able to isolate from the case within the house, then it can extend up to 21 days, 28 days. There are many different caveats for that situation. However, there again, though, if a person is vaccinated and they are named as a close contact and they are symptom-free, they do not have to quarantine. But it is recommended now by CDC that they are tested, COVID tested 3 to 5 days after their exposure and wear a mask for up to 14 days. But there's no set guideline for quarantining a close contact who is vaccinated if they have no symptoms.
Are there, let's talk to the doctors on this one, side effects from the vaccine?
Jay?
Generally, it's more almost like flu-like symptoms like you might experience if you have someone that has had a flu vaccination, for example. You may have aches and pains and fever and chills, but again, they're usually very short-lived.
Okay, this question's for you, Sherry. What is the current recommended quarantine guidelines for infected?
So
that's been my experience. What I've seen with patients is usually the next day, in rare cases, the next 2 or 3 days, some increased fatigue, maybe a low-grade fever, sometimes chills. You know, the one always listed is, you know, soreness at the injection
Right.
site. Well, you had a needle stuck in your arm. It gets sore. Sometimes that has more to do with the shooter than the shot. Sometimes my shots are more sore than others. But all of these symptoms are typically short-lived. I don't know about you guys. I was maybe a little tired the next day
I've
after
seen it
each
where they've
shot.
had no side effects, and I've seen it. The vast majority of my crews are vaccinated, and they've run the gambit. Some, it knocked them on their tail for 12 to 24 hours. Others, you couldn't even tell they even had anything. So.
And the recovery's quick.
Oh
It's
yeah,
quick, yes.
I guess it was explained to me that it hit them and it went away as quick as it hit them. I mean, it's like instantly get better, or instantly get sick and then instantly get better in about 12 hours.
Okay. All right, let's, we don't have a whole lot of time. We've got about 15 minutes. Let's do this. Sherry, you've made as far as vaccinations go, what I've noticed over the last, especially the last 60 days, as far as what the health department is doing, as far as making vaccinations available, is that you guys are trying to make it as convenient for us as possible to be vaccinated. So tell us a little bit about what the health department's doing as far as making the vaccine available.
Well, you're right, Bill. We certainly don't want lack of availability to be a reason that people aren't vaccinated. And the most recent thing, we've made changes throughout the year, of course, or ever since the vaccine became available in December. But our most recent change has been to move basically everything COVID that the Hamlin County Health Department provides, move it to the former front entrance of Morriston Hamlin Hospital. And that change occurred just this week on Monday. And we're really grateful to Gordon Litz for approaching us with this idea because when COVID came about, the front doors of the hospital were no longer accessible, to the public. The front parking lots, which is like 3 tiers there, was not used anymore. The drive-through was not used anymore. So with our current surge, with the Delta variant, and then also knowing that the booster shot for everyone will be coming about in the very near future, and knowing also that we needed to maintain full speed with all of our regular health department services, and there are many ands here, considering that the cooler weather and bad weather months are upon us, we decided to give this a try. So what we're doing now, we have a drive-through scenario for everyone to be able to come up to the former front entrance of Morristown Hamlin Hospital, go up the drive, and on Monday, Wednesdays, and Fridays from 8 to 11 and 1 to 3 receive their COVID vaccinations. You don't have to have an appointment. You can get the first dose, you can get the second dose. If you're immunosuppressed, we are giving that third shot now to those individuals. Some people like an appointment. You can even still go online and actually get an appointment time if you want, but it's very easy to access that. Then what we're doing, and it is the Pfizer vaccine, and there's no charge, of course. Then on Tuesday and Thursday mornings at the same location, from 8 to 11, we are doing the on-site PCR testing, and it's also a drive-through scenario. But the major change in the testing services offered with the health department has to do with the fact that for everyone who qualifies, we're just automatically giving out the Everly Wells self-test kit. and the Everly Wells is a PCR test. So to qualify to get one of these, an individual has to be 16 or older, have a smartphone, and have their own email account, which a great deal of our population do have that. So when they come to the hospital, we have a checkpoint there at the entrance, and we've just had one day in practicing this. We'll be better at it tomorrow on Thursday, but at the checkpoint, we see if they meet that qualification, and we give them the Everly Wells. We give them the instructions. It goes in a prepaid box, so they pay nothing, and they just drop it in a UPS box. So they can get their box and then just quickly exit at the lower level. If they do not meet those qualifications, which in most cases it's been parents bringing children, who are under 16 to be tested. And then the other primary reason is that some of our elderly population especially, may not have their own email account. In that case, they would go on up the driveway under the portico there at the hospital, and we would do the on-site swabbing test. The results for both types, the Everly Wells and the on-site PCR testing, for the time length for coming back is about the same now. It's about 2 to 3 days. That has increased somewhat because the volume of testing has increased tremendously. But we're giving out a lot of the kits. They're expensive kits, but there's no charge. So we're trying to take care of that need. But we just don't want people to get obsessed with testing and forget about the vaccinations. That's what we really want to emphasize. So when they're there to be tested, we're also really, really encouraging, unless they have symptoms, unless they're actually sick, why don't we go ahead and do your vaccine while you're here? Or why don't you just run them down to the health department on Tuesday and Thursday mornings? They can get it at the health department and just walk in. So that's basically what is our new normal, I guess you would say, for health department services. If people, related to COVID, if people just walk into the health department because they're not sure, then they're going to be directed, what to do. If people walk into the health department and can't go to the hospital for some reason for a vaccine, we're going to give them the vaccine there. We're trying very hard. Don't turn anyone away for a COVID, vaccination. So.
One thing I have noticed with the health department is, as far as the vaccine goes, is they're doing everything they can to respond to those who want to be vaccinated and make it as simple and convenient as possible. So,
could I add one other thing?
Go right ahead.
We have Tuesday and Thursday afternoons that we're trying to hold available to go off-site to locations in the county to make it more convenient. So at this point, every Tuesday afternoon, we're still going to Health Star in the main office building and a kiosk there to do vaccinations, and we've been doing that now for about 2 months on Tuesday afternoons, and that's open to the public. Anybody can just walk in there. And then Thursday afternoons are scheduled basically on until about mid-October with different locations, such as tomorrow afternoon it's doing the second doses at the Cook deboning plant. And then it's Tough Torque after that, and then it's Iconics, So many of these are industries or community locations. We have been doing them at the OLA English classes on Tuesday and Thursday evenings. And then this Saturday we'll be teaming up with Cherokee Health Systems to offer them during the International Food Festival that's at the farmers market. But if anyone knows any other locations or places where you want to schedule us, please just call the health department and ask for me, Sherry, and our phone numbers 423-586-6431 and press 0, and we'll get you on the schedule.
We've got time for about 2 more questions, so we'll just open this up for everybody to respond to. If you have tested positive for antibodies, should you still get the vaccine?
If The antibody tests are not particularly sensitive. In other words, you could have antibodies and the test not detect them. And then there's cases where you have antibodies, but you can't quantify. There's not a test out there that can accurately detect how like a number or a variation of how strong would your response be. Basically, the tests are yes, you have antibodies, or no, you don't. And sometimes I've read the figure around 60 to 70% accurate. So we just don't. That makes logical sense that I get my antibodies tested, and if I'm at a certain level, then I don't need the vaccine. Or I've had the vaccine, but it's been 8 months. I want to check my antibody level, and if it's high enough, I don't need a booster. Unfortunately, that test doesn't really exist.
Okay. Anything to add?
I had a question.
Yes, sir.
If I get sick, how do I get a monoclonal infusion? How does that happen for someone that tests positive for COVID? And they're early in their illness.
There is actually one outpatient center here in town. It's Brockwell. Thank you. Brookwell, that's correct. For our ER patients, we're actually, just a few weeks ago, they found that those monoclonal antibodies could also be administered as shots, as a series of 4 shots. So we're trying to reserve this for our ER patients that we see. But yes, there is an outpatient center here in town that can administer those monoclonal antibodies as an infusion.
All right, then, let's see, how do we know if someone has the Delta variant?
So you can honestly say that if you're infected, you have the Delta variant. It is by far, since at least 4 to 5 weeks ago, that was at least 90+% of cases. So yes, if you're infected, you have the Delta variant.
Let's see, there's lots of questions about getting the vaccine with specific illnesses. We need to remind people to talk to their physician about their concerns. If you have any questions about being sick or one of the things that we want to stress is if you're, reluctant to get the vaccine is to do your research, talk to your healthcare provider, talk to the professionals, and we hope that tonight has provided some of that information for you, and that the professionals here on this panel have educated you some and given you some peace as far as whether or not to be vaccinated. We want to thank you for tuning in and watching, and we hope that you'll share some of the information that these professionals gave tonight and share it with your friends and family. Digest it. We will try to post the video onto the county webpage, our YouTube channel, and so that you could watch it again, or you can refer it to other people. So we just I want to thank you again for tuning in, and I want to thank the panelists for taking your time and joining us and using your expertise to answer the questions. And just thanks. Thanks for all you do for our community. Folks like you is what makes Morristown and Hamlet County a great place to live, work, and to raise a family. So again, thanks for viewing, and we just want to say good night.